Okay, everyone, we are ready to get started. Thank you to everyone for your patience as we get launched a little bit late this evening. But we really appreciate, hopefully everybody's had extra time to catch up with friends and colleagues and have seconds of the food. There's still more available. If anybody would like a little bit more, please just let us know. So before we begin tonight's program, just a few housekeeping items as always. Please remember to turn off your cell phones. If you do need the restroom, it's just down this hallway here and to the right. After the lecture this evening, we're going to be doing a Q&A. In that time frame, please raise your hand and wait for someone to come to you because we do need to use the microphones given that the lecture is webcast. So just raise your hand and we'll have someone running around with the microphone so that we can all hear you. If there's anything you need during the lecture, please just raise your hand. We have several volunteers here to help with any mobility needs. And at the end of the lecture, please remember to fill out the survey so that we can get your feedback, which is really valuable to us for planning for future lectures and to plan for the Knowledge in Motion series as we move forward. So we'll begin in a moment as soon as we have it clear for the webcast team. Ready? Okay, great. So thank you again, everyone, for joining us at the Spaulding New England Regional Spinal Cord Injury Center Knowledge in Motion program. My name is Dr. Sherry Blauet. I serve as the Director of Dissemination and Knowledge Translation for the center. Welcome also to our webcast attendees. This evening we have people joining from 29 states across the US and also from countries such as India, Mexico, and Canada. So thank you to everyone who's joining online. I'd like to quickly introduce our speaker. We are really honored this evening to welcome Dr. Christine Sang to join us for our lecture, The Management of Chronic Central Neuropathic Pain Following Spinal Cord Injuries and Disorders. Dr. Sang is truly an expert on this topic. She's a Director of Translational Pain Research at the Department of Anesthesiology at the Brigham Women's Hospital and Harvard Medical School, and Associate Professor of Anesthesia. She previously served as the Associate Medical Director of the Pain Research Clinic at the National Institutes of Health, very impressive position, and is the founding chairman of the Medical and Scientific Advisory Committee for United Spinal, as well as the director of the Rick Hansen Institute. Dr. Sang is joining us this evening, and I really think this is an important topic for those of us in the spinal cord injury community, where so many people deal with managing pain in the long term. And we're really looking forward to this lecture to both provide translation in terms of the current state of the science, but also the way forward and management strategies. So let's please welcome Dr. Sang to the podium.
All the water I need. Should we use this? Would you like?
Got the lab.
Okay. And this is the mic for the.
Yep, that's the mic for the phone line.
Thank you. And I'll turn this on. Okay.
You can just advance the slides by hitting the arrow.
Can you raise this just a little bit?
Sure.
Thanks. Sherry, thank you so much for your kind words. So today I would like to talk about an approach to the management of chronic pain following spinal cord injuries and diseases, with a special emphasis on central neuropathic pain, because it is so difficult to treat central neuropathic pain, and it affects more than half of those who've sustained spinal cord injuries and disorders. So just some disclosures. I'm particularly committed to the community of those with spinal cord injuries, and I've been, since our first grant in spinal cord injury now almost 23 years ago, and I'm a caretaker. I was a caretaker and a family member of someone with spinal cord injury, and that was my father. So this is very near and dear and personal to me. So now, chronic spinal cord injury can take on different characteristics and with different distributions. So it can be characterized as chronic and constant and unremitting burning pain below the level of injury. It can be characterized as a band-like distribution of constricting, like a rubber band, tight pain at the level of injury. It can feel as though you've been lifted and dipped into a pot of burning hot oil, right? It can take on all these different characteristics. And in fact, it reflects the complexity of central neuropathic pain and the challenges and opportunities that we have to try to treat this type of pain better. For the half of individuals with spinal cord injuries that have central neuropathic pain, it's really important to try to determine what component of the overall pain syndrome may have a significant contribution from this central pain. The reason is that if the pain generators are within the cord, it can require some pharmacological tricks, tricks with different medicines, different combinations with what we have now. And in fact, there's a lot of research going on in this area with the identification of new targets, and with the identification of new targets comes the possibility of new treatments. So it's actually a really exciting time in many respects in this field. Sorry. I guess I'm the only one who can get it all the way back to the top. Okay. Now, these are the common descriptors that we hear from patients who have chronic pain following spinal cord injury: burning pain, aching, throbbing, cramping pain, tingling, pins and needles or electric pain, cold pain, shooting or stabbing pain that lasts either a few seconds or less, or lasting several minutes or longer, that constricting, swelling, tight pain, and then pain that's really there when you do something, when you evoke it by either light touch or cold stimuli, or certain exacerbating factors. So these are all common descriptors, and these are actually descriptors that we look for when we run clinical trials, so that we can try to determine or make an inference about what general sets of mechanisms might be at play. And then we use special kinds of tests, not just us, others use these special neurophysiological tests to try to help us make inferences about mechanisms that are important to the integrity, the validity of the trial. Now, this schematic illustrates the complexity of pain, chronic pain, all pain following spinal cord injury. And it's really important to try to tease out the different signs and symptoms. And the reason is, once again, it helps us determine what types of drugs we might want to use in what kind of proportions, relatively speaking. And that is because there may be more of a contribution from this kind of pain versus another kind of pain. Perhaps the musculoskeletal pain will benefit from this group of drugs or this class of drugs, and the central and peripheral neuropathic pain components might, actually the central neuropathic pain component might benefit from another class of drugs, and then the peripheral neuropathic pain component there may be some overlap, but in fact, there may be a response to yet another class of drugs, and the dosing is important. So what's really important here is that we balance what we think are mechanisms of pain together with the medications that are available to use. Now, I want to emphasize that despite the different patterns and varieties of pain syndromes within the overall broader spinal cord injury pain syndrome category, in fact, there's been a lot of research that's been focused on trying to establish definitions, trying to figure out, perhaps there may be risk factors for one kind of pain, better treatments for another type of pain, to determine the best treatment strategies possible for broad sets of pain syndromes under the broader diagnostic category of chronic spinal cord injury pain. So there was a very nice study published in 2016 and by Burke et al. And what they found was, in a pooled analysis, they evaluated 3,000 studies and pulled a sample of them and found that when they did a pooled analysis, the results showed that about 55% across all studies, the prevalence of central neuropathic pain was 55% on average and across all studies. And that's consistent with what we see in the literature across a large body of data. So that's actually reassuring to be able to identify that type of information. And of those, approximately 20 to 30% had the distribution that's considered what we call at level, or a segmental distribution of central neuropathic pain, and about 20%, approximately 20%, have a clear-cut distribution everywhere below the level of injury. And these are the two most common distributions of central neuropathic pain. It's important to be able to pool the data. The reason is that when we see our patients and they use a variety of descriptors, the distribution of the pain is to us really important. So it's the descriptors of the pain, it's the distribution of the pain, it's the temporal relationship of the pain, different kinds of pain, relative to different activities and relative to different types of stimuli. It's the presence of pain, perhaps at the skin level, like a sunburn-like pain, to like touch or cold and so on. That's really important for us to determine, for us, all of us as a team, to determine what mechanisms we need to consider, and therefore what medications we need to consider. So this is actually the first step right here, making the diagnosis. The first step in our approach to treating chronic pain, and more specifically, chronic central neuropathic pain. Now, I do want to say that central neuropathic pain does involve mechanisms that are somewhat complex. In fact, as with pain following peripheral nerve injury, in central neuropathic pain following spinal cord injury, there are innumerable pain mechanisms, and this is expected and shown in a variety of different labs, in several different labs over about 30 plus years. Really important to remember that mechanisms are important to us, to all of us, because if we only rely on broad diagnostic definitions like chronic SCI pain, it doesn't help us enough. When we consider any chronic pain syndrome based on the etiology of the insult or the anatomical distribution of pain, it's not helpful enough. We need to delve in more deeply, because otherwise, just using, say, chronic spinal cord injury pain as the diagnosis offers little framework for the clinical management of the pain. More than one mechanism is likely to be operating in any single patient. One mechanism may be responsible for many different symptoms. The same symptom in any two patients may be caused by different mechanisms. So it is important that we together work carefully in trying to tease out different contributions of different types of pain. Now, that's what I mean when I say here, inferring underlying mechanisms, and that is an important step to then treat the underlying condition, improve symptoms, to achieve our goals of improving physical and general functioning, reducing psychological distress, and improving overall quality of life. So I'd like to take a step back and just ask, how do we define pain? There are actually many different definitions, but the body of different of definitions that fall under the umbrella definition of pain, we generally take from the International Association for the Study of Pain, the IASP, and they define pain as an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now, sometimes pain is important and it's good pain, right? If I were to touch a hot stove and I would reflexively withdraw to protect myself from getting burned and having persistent inflammation. That actually is good pain, okay? We call that nociceptive pain, protective pain. The IASP defines it as arising from actual or threatened damage to typically non-neural tissue, and is due to the activation of the nerve endings, pain fiber endings called nociceptor. So as an example, musculoskeletal pain is typically considered nociceptive. Neuropathic pain is pain that arises as a direct consequence of a lesion, trauma, or diseases that affect the nervous system. So peripheral neuropathic pain is pain that's caused by a lesion or trauma or disease of the peripheral nervous system, like a peripheral nerve. And central neuropathic pain is pain that's caused by a lesion or trauma or disease of the central nervous system. What we have benefited from are classification systems. And this is the latest one from 2012. And it is based on the IASP definition of different types of pain. So here you can see that nociceptive pain in the context, now we're looking at the context of chronic pain following spinal cord injury. Nociceptive pain is chronic musculoskeletal pain. I'm referring now just to chronic SCI pain. Musculoskeletal pain can be associated with mechanical instability, with secondary overuse or pressure syndromes, with abnormal loading of joints, with muscle spasms and contractures, and central spasticity falls under musculoskeletal pain in this classification system, as does visceral pain. Okay, there have been many different classification systems actually, and they have generally followed this basic framework, but where visceral pain and central spasticity lies has been a question. On the other hand, what's important here is to understand that these are other pain syndromes that require additional attention. Now, neuropathic pain, as we've already described, can be at level or segmental, or below the level or diffuse. And these are terms that have been included in different classification systems. Now, at level pain is a characteristic band-like distribution. This at-level pain can be associated with nerve root compression in traumatic SCI, but a radicular pain, that is pain associated with an isolated inflammation or compression or some sort of injury to the nerve root, actually looks different. The distribution is different. So nerve root compression, in fact, falls under at-level pain in this classification system, but keep in mind it's in the context of SCI, in which a nerve root compression oftentimes will accompany the spinal cord injury. A syringomyelia is important to remember, because if in fact it's treatable, if there can be a surgical decompression as an option for treatment, that is potentially very helpful. Below level or diffuse central neuropathic pain, we've already described. Spinal cord injury related pain, cauda equina, such as with a cauda equina lesion, which is also considered a peripheral nervous system lesion, and other neuropathic pain syndromes, typically a peripheral neuropathic pain syndrome, say above the level of injury, such as with overuse pain syndromes, in fact, also need to be considered and are part of this classification. Now, this is a handful of mechanisms that I thought I would put up on the screen just to give you a sense for the 3+ decades of research that's been going on. There are a number of mechanisms, and every month there are new targets discovered. There's more research being discovered. New therapies are being developed based on this research. And I just want to impart that there's tremendous hope for the discovery of new therapies. And that's really important to remember. So central nervous system sensitization, that's that revved up central nervous system at the epicenter of the trauma, in the peripheral nerves associated with the injury, that are traumatized, associated with the injury itself. And even at supraspinal sites where pain is processed, there can be sensitization. I think those of us who who have central neuropathic pain can sense that the whole system is revved up. Targets that have been discovered and are being continuously discovered include channelopathies, sodium channels, voltage-gated calcium channels, glial mechanisms, free radical production. There are so many new mechanisms that are being discovered, and it's quite exciting. Now, basic science research is important, but I want to make sure that we understand that in our context, it's important because these discoveries inform the development of new treatments, and the new treatments that are on the horizon include neural stem cells, Schwann cell transplantation, cell transplantation, gene therapies. So, and I think that we will hear more and better technologies and options for therapies. It's on the horizon, and it may not be today, but it needs to be followed carefully and closely. And once again, there's tremendous hope for new treatments. Now, this is what an animal model correlate of central neuropathic pain looks like. And it's because of the more than a handful of different models of central neuropathic pain and spinal cord injury that we're able to actually see data that evaluate these new therapies in these models. This is really the animal model correlate of many of us. And in fact, new models are also being developed for a variety of different treatments. So once again, it's worth keeping in mind that there are many in the spinal cord injury and central neuropathic pain space who are committed to these discoveries. Now, we need to remember that there are chronic physiological changes associated with spinal cord injuries, and they include AD, autonomic dysreflexia, orthostatic hypotension, bowel and bladder dysfunction, and so on. And why is this important? For those of us with chronic pain following spinal cord injury, and most notably central neuropathic pain, we know that many of these can actually worsen pain if not controlled. And furthermore, what we can control needs to be controlled. Otherwise, it makes the treatments more difficult to achieve success, an analgesic response. And then, of course, most importantly, is that it can affect safety. And it's all about safety, ultimately. So we have to remove the potential exacerbating factors. We have to treat urinary tract infections, constipation if we can, decubitus ulcers, and anything that can contribute to bladder and bowel distension, anything else that can contribute to bladder and bowel distension. Now, let's talk about pharmacological treatments. Because as I mentioned, we have not just the spinal cord lesion itself, changes at the epicenter of the trauma, and persistent neuroinflammation associated with that. Even at a low level, it can contribute as a driver of central neuropathic pain. There can be sensitization, that is that revved up system extending a few segments above and below the epicenter. There may be peripheral nerve injury, and there is likely, as with many pain syndromes, not isolated to central neuropathic pain, but with many pain syndromes, we have sensitization that can extend to supraspinal sites. So typically we do need systemic medications. Now let's just take a step back and look at the nociceptive or musculoskeletal pain. And I want to say as an aside that if there's musculoskeletal injury below the level of injury, of spinal cord injury, it is possible to have no symptoms except for heightened spasticity or heightened other pain syndromes. It may be very difficult to localize it, and it may be asymptomatic, in fact. So this is really important to note, because remember that protective pain helps us to prevent further damage. So anytime you suspect an injury below the level of injury, musculoskeletal injury below the level of spinal cord injury, it's really important to bring this to your doctor's attention. Now, treatment of musculoskeletal pain should target inflammation, instability, weakness, etc., and should address the possibility of overuse with physical therapy, strengthening exercises. In terms of medications, acetaminophen or paracetamol, and limited use of NSAIDs might also be helpful. Now, I say limited because, and I'll bring this up in a bit, we need to always make sure that we stay hydrated, that our kidney function is optimized, that NSAIDs don't hurt our kidneys. This is true generally, and it's especially true in following spinal cord injury. Now, visceral pain and SCI is typically associated with constipation and bladder distension. Certainly, urinary retention and recurrent UTIs may, as I mentioned, only manifest as an increase in pain and central spasticity, and now central neuropathic pain, with the exception of syringomyelia, which, as I mentioned, can be treated surgically depending on the pressure it generates, is typically treated with medications, systemic medications, including oral medications. Now, there are a number of commercially available non-opioid analgesics. There's one that has been approved specifically for the use in central neuropathic pain following spinal cord injury. That is pregabalin, also known as Lyrica. Now, pregabalin is structurally almost identical to gabapentin. The differences generally are in how well they're absorbed, where they're absorbed, how long they last in the bloodstream, which affects how well they get to the target site, and so on. But basically, structurally, they're very similar and work in very much the same way. Choosing one versus the other, independent of issues of cost, will depend on a number of factors that need to be considered, like activities, timing, adverse effects, and when they're better tolerated. If it causes some sedation, it's important to be safe, right? Safety first. So best to take it, for example, initially at least at night before bed so you can sleep off the effects. And in fact, tolerance can develop to some side effects. It can to the sedative effects of gabapentin and pregabalin. I'm going to skip this, but I put this here because these animal models have helped us so much. Pharmacological assays have been performed in these animals. They inform what we do in clinical trials and our choices of medications clinically. Now, in terms of peripheral neuropathic pain syndromes, it's important to note that there's a and I'm speaking about peripheral neuropathic pain syndromes broadly, that in fact, it's been found over several decades that there's a differential effect of different analgesic medications that work differently and the type of peripheral neuropathic pain. And in fact, that's something that we need to consider as well when treating peripheral neuropathic pain in the broader pain syndrome following spinal cord injury. Now, in terms of challenges, actually, let's not say challenges, let's say considerations of pharmacological management of central neuropathic pain in spinal cord injury. There are some that are unique to SCI, okay? Or at least need to be considered in SCI, and that is, one, multiple pain syndromes are typically present in the same patient, as we've said. So musculoskeletal or overuse pain syndromes, deafferentation or central neuropathic pain syndromes, central spasticity, scoliosis, and so on. So it's important to define all the contributions to the overall pain syndrome, as I've already mentioned. Number two, the pain mechanisms involved differ in each patient, and even within each pain syndrome, within the broader pain syndrome, such as within central neuropathic pain or musculoskeletal pain and so on, there are likely to be a number of pain mechanisms involved, and they are likely to differ in each patient. So this is independent of other factors that we always do consider as well, like age, the type of lesion, the level of injury, the time since injury, the distribution of pain, associated medical problems, and so on. Number three is a point I've already made, which is that because supraspinal sites may be sensitized, are likely sensitized in addition to spinal sites, systemic medications are required, at least in part. Number four, another point that I've already made, which is that
now 7:30 p.m.
Other-
The hours will be over in half an hour. The time is now 7:30 p.m. The visiting hours will be over in 30 minutes.
other chronic conditions associated with SCI may impact pain. We've already said this. The most common considerations are autonomic dysreflexia, bowel and bladder dysfunction, decubitus ulcers, any possibly the development of glucose intolerance. And so these are all considerations that are at play. And then finally, there are certain side effects of analgesics that are unique to SCID. Gabapentin and pregabalin have been shown to be effective for central spasticity. They certainly can, at high doses, interfere with ambulation, even standing, and can interfere at high doses, typically, with the ability to use assistive devices. So it's important to evaluate and reevaluate dosing activities, goals of treatment, and so on. Analgesics that can worsen bowel and bladder distension can worsen, for example, AD and certainly pain, spasticity, and so on. An example is amitriptyline, which has an anticholinergic activity. And so anything that can worsen, for example, constipation needs to be monitored. And then we already mentioned the use of NSAIDs, which I prefer to limit to only brief periods, like 1 to 2 weeks at a time. There are other treatment options. I won't have time to go into all of these, but you can see in the slide, of course, heat massage therapy, acupuncture, exercise, physical therapy, self-hypnosis or hypnosis, biofeedback relaxation, cognitive restructuring, neuromodulation, intrathecal pumps, magnets, mirror imaging, Botox injections for central spasticity, possibly some nerve blocks, surgical procedures if indicated. It's really important, though, to choose carefully and consider the broad picture and the contribution of the different mechanisms of pain that you think, that you and your doctor and your team thinks are at play. These are some of the medications that are commercially available. And in fact, I've already mentioned several of these. For central neuropathic pain, first-line treatment are the gabapentinoids. Now, worth showing you some data about the motor component, about preservation of motor tone. You can see here, now in this particular study, they looked at really low doses and really high doses. We didn't have any middle doses, but you can see here that there is a risk of very high doses, and so it's worthwhile always remembering, and you typically would do this anyway with your doctor, but to titrate up, reassess, titrate, assess, titrate, assess, and make any changes necessary. Once again, goals of treatment need to be broad. It's not isolated to the gabapentinoids. Really, most classes of drugs at high enough doses will interfere with tone. Now, this is one example. This is an example from an old study. They looked at a series of 3 NMDA antagonists. The NMDA receptor is located on neurons in the spinal cord, and then cells that are actually not considered neurons at all. They're like the fibroblasts under your skin. They hold the spinal cord together. It turns out that administering an NMDA receptor antagonist is analgesic. In this set of slides, set of graphs, you can see that even with NMDA receptor antagonists, we can see, with 2 of these at least, changes in tone. So dextromethorphan is the only one that is not affected. It does not affect tone. You can see, though, and you need high doses of dextromethorphan, but you can see that even with other NMDA receptor antagonists, we have a similar issue. So it speaks to assessing and reassessing every management step. Okay, so this is now the final set of slides. Chronic pain following spinal cord injury involves multiple mechanisms for its onset and maintenance. May involve central neuropathic pain, peripheral neuropathic pain, and nociceptive or musculoskeletal pain and peripheral neuropathic pain. It may be above the level of injury, For example, in overuse pain syndromes, or compressive mononeuropathies, or peripheral neuropathies, again, typically from overuse, or at the level of injury, or at and below the level of injury, or below the level of injury. These need to be defined, they need to be characterized, and then we need to design the most appropriate treatment strategy for each one and determine what is that balance that is necessary to achieve our goals, our treatment goals. Okay, so I'm going to read this to you. There's much hope on the horizon for new treatments for chronic pain following SCI, particularly in the area of central neuropathic pain. A growing body of research has identified not only specific mechanisms of pain to target, but also new ways to better deliver drugs whose analgesic effects are known. This came from the CDRF Christopher and Dana Reeve Foundation Pain Management Booklet in 2019. Actually, that was my quote. Okay, so resources. There is that CDRF booklet that just came out. You can call the CDRF and they can send you a copy, or you can just download it off the internet. The Model Systems Knowledge Translation Center has a very nice booklet called Pain After SCI, and this is available online also to download. And of course, the United Spinal Association Resource Center is always available to everyone with spinal cord injuries and disorders. Thank you so much. I can't end any talk without just thanking my whole group. For over 20 years, we've been focused on pain following spinal cord injury, and we will never stop. Thank you.
Okay, thank you very much, Dr. Singh. I'd like to quick note before we start the Q&A that we actually have the Christopher and Dana Reeve Foundation booklets in the back. Melissa, give a wave, Melissa, has copies. If everyone is welcome to grab one on their way out. We have 50 total. So please, if you could just take one to make sure that there's enough for everyone, that would be really appreciated. And if you need more copies, there's information there regarding how you can find that online. So we'll now open it up for question and answers. Remember, if you have a question, please raise your hand and we'll come to you with the microphone so that the people on the webcast can also hear your question.
Hi, I'm wondering, I noticed on your outline up there, it said that leg spasms were musculoskeletal from trauma there or whatever, and result like from overuse or something. I have leg spasms that are getting worse, and it's not like from overuse.
I know.
Because I mean, the fact that you said they were musculoskeletal and not neuro in origin, and I'm just wondering, like, would you consider this as pain, as
Nociceptive pain? No. So let me just qualify it. I put up the latest classification that was published in 2012 by Bryce et al. Now there are many classification schemes, and how they differ has included where visceral pain and where central spasticity and where some other pain syndromes fall. And I'm with you. Central spasticity, I also believe, should not fall under musculoskeletal and nociceptive pain. So absolutely, you're right.
did the spasms represent pain or what? I mean, I can't deal with it.
I know.
By that much, but, is it
We treat spasms. So the answer is yes. There are spasms actually aren't typically painful to most. And they don't fall directly under the category of neuropathic, nor do they fall under the category of musculoskeletal, reflecting the fact that we treat these spasms with a different set of medications. Those antispasmodics include drugs like baclofen, drugs like tizanidine, benzodiazepines, like Ativan or Valium. In the old days, we would use dantrolene. There were a number of different drugs that we would use specifically for central spasticity. And you hit the nail on the head. You're absolutely right. Classification schemes have not been perfect.
So
They can only guide us so well.
consider a lump under pain that spasms are considered neuropathic.
So we don't consider spasms in central spasticity to fall under central neuropathic pain specifically. We consider it to be a separate category. And where it falls under the nociceptive and neuropathic continuum has differed among classification systems.
Okay, thank you.
We use these classification systems for a variety of different purposes. Many of us use the classification systems for different research agendas. Most of us also use them to help clinically. They are only so good, right? And ultimately, it's about the individual. So they have their limitations, but this speaks to why it's so important for the assessment and treatment of various pain syndromes to be personalized and customized.
Okay, thank you.
I know my personal experience when I was hurt is I ran through pretty much the whole medical dictionary and didn't find any of them did very much for me other than getting me hooked on fentanyl, which did nothing good for me. But I'm surprised that you haven't mentioned cannabinoids and CBD because I know there seems to be an awful lot of anecdotal evidence that many people have been getting benefit from it. I've personally been trying it and finding that it helps at least as much or more than anything that the doctors gave me.
Helps for what?
For just, I have a lot of swelling in my feet. It helps some with pain from that, and just arthritis pain and various other stuff. Most of my pain doesn't seem to be neuropathic, but it only seems to help that. But I hear a lot of people who say it helps with spasticity. I know a lot of people who say that they have various other things that it helps with. And I'm at the point of saying that to me, it should be like the first thing you try, just because it's got no known side effects. Like, it's not going to do any harm. Whereas a lot of the others seem to have some really unpleasant side effects to them. So why start with something that doesn't hurt before you go to the stuff that does bad things?
So in response to your question about why I didn't talk about opioids and cannabinoids, it's because opioids I could have mentioned it, I'll mention it now, thank you for bringing it up. Opioids are associated with bowel bladder distension and other effects. So moreover, their systemic effects on the benefit of opioids in non-malignant neuropathic pain syndromes, including central neuropathic pain, is not clear. And that's in part because of conflicting data in the literature. Now, it's not to say that in musculoskeletal pain syndromes chronic musculoskeletal pain syndromes, there may not be a role for opioids, particularly in well thought out doses, but that's not really a topic of discussion for this talk. On the other hand, we can talk anytime after we're done, and specifically about opioids.
No,
With
I
respect-
wouldn't wish opioids on my worst enemy.
Okay.
My current policy is no opioids for any reason at any time, and I don't care why you want to give them to me.
Yeah.
Cannabinoids, cannabinoids, and cannabis, and CBD is specifically what I'm doing, seem to be much more useful and helpful, and don't have any of the bad baggage that opioids are loaded with.
Yeah, so there are a lot of data, but the systematic data that can be clearly evaluated and even pooled to come up with inferences are a challenge. So there have been over a handful of systematic reviews over the last decade, and even almost a handful over the last 2 or 3 years that have essentially said we need more data. On the other hand, there are moderately strong data to support the use of cannabinoids generally in MS, central spasticity, and pain. On the other hand, it's not clear what type of pain, but certainly in central spasticity, and I think we can extend it to central spasticity and spinal cord injury, there is likely to be a role. The data seem to be supportive. What we don't know clearly is whether or not we can tease out the different components of CBD. What we do know, what we also don't understand is the role of, are you using CBD topically?
I'm currently using both.
Okay. The data in pain using topical CBD are somewhat weak. So I think the bottom line is that we just need to generate more data so that I can answer this question more intelligently the next time.
I can appreciate the need for more data, but just it seems like something that it's, first do no harm, and it's something that we know from all evidence. I mean, as far as we know, there's never been a fatal overdose of marijuana. I mean, so it's like, first do no harm, so it's try something that does no harm and see if it works, then go to the other stuff that's stronger.
Yeah, so the closest data that we have are data in MS for central spasticity and broadly pain, but really it's central spasticity.
We've got a question from the webcast. Can you speak about the evidence for ketamine infusions to treat neuropathic pain?
So there is a relatively large body of data using ketamine at different doses, but including ketamine at low doses to treat a variety of different pain syndromes, including central neuropathic pain. And as with other NMDA blockers that I showed you some of those preclinical data, NMDA receptor antagonists are effective. The real question is what we call the therapeutic window, that the risk of side effects to benefits, and how practical it is to administer ketamine to patients chronically. Now, ketamine is particularly interesting in central neuropathic pain, in part because its mechanisms of action include not just the NMDA receptor antagonism, but also it's a sodium channel blocker. And that is a very, that's a very interesting and potentially, at least in the clinical trials that we've run, a mechanism of action that is potentially a good one. So there is a role for ketamine, but the question is delivery.
All right, how do you spell ketamine?
Ketamine.
And what is
It is structurally, it's a low affinity NMDA receptor antagonist. It turns out that it can act like a higher affinity antagonist in part because structurally it doesn't diffuse away from the receptor. So, so in fact, it's as though even administering low doses, because it gets across the blood-brain barrier really quickly, in spinal cord injury where the blood-brain barrier is disrupted already, it may be less of an issue. But in fact, ketamine gets right to the target site very quickly. The problem is that the receptor that it targets is involved in different types of functions. In fact, frankly, the neurotransmitter for that receptor in the body, glutamate, it's ubiquitous, it's everywhere. So it's responsible for normal cognition as well as abnormal processes like pain. So when we give medications, we have to think about all of the effects, the good effects and potentially the effects that are more harmful. So it turns out that we have to think carefully about ketamine and its effects before we give it chronically for central neuropathic pain.
I'm not sure what type of pain I have. I know I did some studies with you at Brigham Women's, and I have both kind of pain. It was the dextromethorphan.
Ah, yeah.
What happened with that? I mean, I did get pain relief, but then there's
You
no-
got pain relief? Yeah. We are trying to make that available. We're working on it.
That was a long time ago.
It was a long time ago. Please feel free to give us a call and we'll work with you on how we can find a way to get it to you. It's not covered by insurance.
So when when I sustained spinal cord injury and the nerve impulses were interrupted because of a lesion, and that's the nerve growing out of the spinal cord, is that growing back? No.
That's a good question and one for the Spaulding team. But what we do believe in part is that regeneration can also be associated with new onset of certain types of pain.
Well, that's why I think my pain's getting worse. I'm 37 years post spinal cord injury. And I go to the restroom and so I'm thinking that slowly these nerve endings grow back because the pain is getting worse.
That is something that we can talk about offline because it is one of many, many, many possibilities for why your pain is getting worse. Don't worry, I'm not going anywhere. We'll talk after the game.
More webcast questions. If you have burning, throbbing pain in the lower legs, what kind of pain would this be classified as?
In addition to talking about the pain, it's important to examine each individual. And when I say examine, I mean actually use a variety of different stimuli to see what happens when we administer, say, a light touch, or cold sensation, or a warm sensation, or a pinprick, and so on. And mapping these areas can also be helpful. So there are a number of, in addition to a standard physical exam, there are a number of additional tests that help inform exactly what it is that we need to know to choose the right treatments, to determine the diagnosis, the putative pain mechanisms, and then come up with a treatment plan.
Time for one more question, and I think we had one more from the webcast.
This last question is about pain that alternates every other day and is not responsive to gabapentin or Lyrica. This person is asking about what might cause every other day pain.
I think we need more information than that.
Reasonable answer. Okay. Well, I think, we're approaching 8 o'clock anyway, and we definitely want to be cognizant to end on time, particularly for those who may be having a ride come to pick them up for this sort of thing. So thank you very, very much, Dr. Sang, for a round of applause, please.
And I'm here to answer any further questions.
Perfect. So thank you again, everyone, both those in person as well as those on the webcast, for joining us for Knowledge in Motion. Please be looking for upcoming announcements regarding lectures in 2020. And we hope to be using your feedback to continue to refine the topics that we cover that are of interest to the spinal cord injury community. Please remember to fill out your survey and hand it to someone at the desk, please, if you could, so that we can get your feedback. And please don't forget that there are booklets from the Christopher and Dana Reed Foundation in the back. We have 50 of them, and we love to distribute them tonight so that the information can be of benefit to people with spinal cord injuries, their families, and the spinal cord injury community. So please stop at the desk and see Melissa or Jenny to pick up the booklet. What's that? Oh yes, and we have plenty of extra food. Please, if you're so hungry, go ahead and grab some. And also we do have Ziplocs as well, so that you can take some home for dinner for the next several nights. So please grab some food so that it doesn't go to waste before you head out. Thank you, everyone. We really appreciate you coming tonight, and thanks to those on the webcast as well.